Everybody to Core Insights. All right. Before we get started, I just want to make a few, well, really one quick announcement. Go ahead and upload those 2 slides. So this is not a brand new initiative, but something they've been trying to get up and running. It's an opportunity to get individualized coaching on your operative videos. And so essentially what happens is if you're interested in this, there's a QR code down there, or Dr. Caprice Greenberg, her email is there, or the WSCP at surgery.wisconsin.edu. Any of those are opportunities to get involved with this. And essentially what you do once you sign up is you can upload several of your videos, whatever technique that you want to be coached on. Mostly this is minimally invasive stuff, since that's more amenable to videotaping, but it could also be open surgery too. And you upload the videos, and then they will show them to an expert in your field, and they will give you individualized feedback on those. So I've done this. I've uploaded the videos. It's not too complicated. Sometimes there's like some formatting stuff you have to jump through, but after that, you'll be uploaded in the system, and then you'll get feedback on your video. So there's the contacts. So if you're interested, feel free to reach out. All right. And it looks like Megan's still frozen. So, all right, I think we're gonna start with Matt. Is that right?
Yep, sounds good.
So he's gonna go ahead and give us a presentation, and then Sergio is gonna follow up afterward with some case presentations. I apologize, Matt. I don't have your CV in front of me, so I apologize. So why don't you go ahead and introduce yourself?
Sounds great. Thank you. Yeah, I'm Matt Madion. I just recently graduated from Medical College of Wisconsin in Milwaukee, and then I'm in my fellowship down in Knoxville, Tennessee at the University of Tennessee. So yeah, thanks for the opportunity to talk tonight. You guys can all see my screen, hopefully. So let's see. Just as a brief outline, we'll kind of review the risk factors that we'll address in some of the papers that I'll cover tonight, and then look at some pertinent studies specific to the hernia literature with these risk factors, and then kind of finish with, I guess, what you could say, some conclusions to be made, or maybe more questions. And I think we'll hold off with the discussion until the end of both my presentation and Sergio's. But if anybody has questions throughout, we certainly can take time for that. So some risk factors for particularly wound morbidity and ventral hernias that we'll be covering tonight: diabetes, obesity, and smoking, and immunosuppression. So really, these are things that we think of as modifiable risk factors, or things that we can maybe adjust in some way to try to reduce the morbidity in our repairs. And then finish with talking about sort of how this ties into prior hernia repairs, or how maybe we could avoid it tying into future hernia repairs. So just some definitions here. So surgical site infection, this is in pretty much all of the studies that we'll talk about, is considered the SSI as what the CDC defines at it. So superficial, deep, and organ space SSI. And then surgical site occurrences include anything with the surgical site that don't necessarily also encompass SSI. So some of the examples would be, any cellulitis or necrosis at the site, serous drainage, seromas, hematomas, exposed mesh, and enterocutaneous fistulas. All of these would have, in this literature, been considered an SSO. And then an SSO requiring intervention would be anything, as it says, that would require intervention: opening the wound, debriding it, excising suture or mesh. Not necessarily taking the patient to the operating room for this, but just having to intervene in some way at that surgical site. So start now by looking at just any patients that have multiple comorbidities in general. So there's some pretty well-designed studies that with the QC database that have looked at just the impact of having multiple comorbidities. So This first study that I'll talk about was a database review of close to 4,000 patients undergoing elective incisional hernia repairs. And these patients looked at 3 modifiable risk factors: obesity, smoking, and diabetes, and they divided them into 3 categories: patients that didn't have any comorbidities, patients that had 1 comorbidity, or patients that had 2 or more modifiable comorbidities. And looking at primarily wound morbidity, so SSO, SSI, and SSOPI. And it showed, after controlling for other variables, that patients that had either 1 or 2 or more comorbidities, so those 2 different categories, had an increased risk of surgical site occurrence compared to the group that had no comorbidities. However, between each other, they did not have any difference between that. And then patients that had 2 or more comorbidities were at increased risk for an event that would require a procedural intervention. And then looking at some other variables here within this patient population, patients that were on immunosuppressants, or patients that had larger hernia defect sizes or longer operative time were all at increased risk for SSO. Particularly striking here are patients that had all 3 comorbidities. They were at double the increased odds of wound events. And then when they looked at each of the specific comorbidities in general, like individually, obesity and diabetes were independent risk factors. However, smoking was not. Another study that looked at comorbid patients and multiple comorbidities, this was a single institution review of 88 patients. They were looking here at what were considered ventral hernia working group grade 2. So these were patients that had comorbidities, but were not at risk or did not have any evidence of contamination or prior infection. And within this patient population, they looked at wound events, SSO and SSI individually, and found that patients that had increasing number of comorbidities had a statistically significantly higher risk for SSO, and patients that had a higher BMI were at increased risk for SSI. And then patients that had COPD as a diagnosis were at increased risk for either of those. Particularly worth highlighting here again is that immunocompromised patients actually immunocompromised patients and smokers did not have increased, at least statistically significant difference in this patient population. So that's just having general comorbidities and kind of looking at them as a broad stroke. And so now we'll look at some of these comorbidities individually. So this was a kind of interestingly designed study, also using the QC registry of close to 9,000 patients. This was a multivariate logistic regression model using a relative log odds scale analysis. And they controlled for a ton of covariants. Some of them, I'm not going to list them all, but diabetes, smoking, COPD, immunosuppression, ASA class were all controlled for within this. And then BMI was the continuous variable. And as you can see by the graphs for both SSI and SSOPI, you have an increasing odds of either of those with increasing BMI, and it continues with that. So the takeaway I think from this is that when we consider obese patients, even if they're obese before and after we try to intervene on them in terms of motivating them to lose weight, there's still potentially could be some benefit or detriment to them either losing weight or gaining weight prior to their operation. So now looking at smoking, this was another QC database study that looked at the effect of smoking on elective open ventral hernias. This was a propensity matched look, and they ended up matching a little over 400 patients in each group. So one group was a non-smoker group. So it was a never smoker group. And then the other group had smoked within the last 30 days. And they found that with respect to wound morbidity, the only statistically significant differences were SSO. and primarily due to seroma. So SSI was not statistically significant, nor was any event requiring procedural intervention. Now, I don't think it's worth now just going out and telling our patients, you're not going to get an SSI because you smoke, but it's just another conversation to think about and have with your patient in terms of how much is this affecting them on an individual basis. And then just looking at immunosuppression, this was another propensity matched group looking at 30-day wound events. It ended up being, I think it was 4-to-1 matched. There was 200 patients that were considered immunosuppressed. That means they'd had immunosuppression in the last 3 months before their elective hernia repair. And they looked at not only wound morbidity, but also other morbidity and mortality. And really, in terms of the propensity match comparison, did not find any statistically significant differences between these two groups with respect to wound morbidity, with the exception of surgical site occurrence. And again, majority of those were seromas. So yeah, again, highlighting there was, where's the SSI? I can't find it right now, but yeah, once again, so just SSO was the only difference there. And then I know I'm kind of glazing through this, but I think it's probably worth just having a broader conversation about these topics than really getting to the nitty gritty of the papers themselves. So then taking a step back and looking at how this affects operations in the future, or how we might think about avoiding the need for reoperation. So this was a multi-center database look at close to 800 patients. And they basically looked at patients that had a primary ventral hernia repair, and then patients that had their first reoperative hernia repair, second or third, and looked at multiple variables, including SSI, recurrence, and reoperation. And so interestingly, patients that had reoperation either first through third time had increased risk of recurrence and reoperation, so an additional reoperation, but did not have an increased risk of SSI. They did, however, have higher BMI. And then when looking at the rates of SSI, there were statistically significant, the higher rates of SSI within the groups that were having reoperations. So the bottom of the screen here, you can see that this total group that had all reoperation had I think it was a total of a 30% SSI rate and a 34% reoperation rate with each group. So there are increased risk for SSI and reoperation. And then looking long-term in terms of follow-up, they also looked at the risk of recurrence out into the years. And not surprisingly, with each reoperation, there was a higher rate of recurrence as time went on. And actually theirs was, I think, a 40% recurrence rate out at 3 years there. So probably a little bit higher than some studies, but still worth thinking about here. So finally, just, I know this was like a very, very cursory review of some of these, but some of the take-home points to think about. I think looking at this, there were some things that patients might not consider significant. Sometimes we talk about SSOs and not having to intervene on something is not something significant, but every patient requires a different conversation, and telling them that they're at risk for having something happen at their wound site after their operation if they don't control their comorbidities, or if we don't work on controlling their comorbidities, is a conversation worth having. Obviously, patients that have multiple issues are probably the ones that we need to look closely at the most, because they are at the largest risk. And a single comorbidity might not guarantee a need for reintervention, but still trying to work on getting that improved is probably the priority there. And then thinking about obesity is not a binary issue. So an obese patient might still be obese when you operate on them, but any reduction in their weight could be potentially helpful. And then smoking, I think that requires an individualized conversation. Just because they're not at risk for infection or intervention doesn't mean we can let them smoke or continue smoking through their perioperative period. And then I think we've all learned this, but minimizing the risk for reoperation is key. And I think the conversation there is, hey, listen, if we reduce these risk factors with you beforehand, then we could potentially reduce your risk for reoperation. And I think entering the operation and knowing that we're doing the right operation and reducing that risk for any recurrence the first time around is the best thing for the patient. And then generally, I think long-term, looking at, as we get this more, I think, detailed and accurate data about surgical site occurrences, how will this affect our repairs in the long run in terms of, multi-year, 5-10-year look studies. But that's all I have. So I can turn over to Sergio, or we can talk about this now, however people want.
I think, Matt, that was a really good review of a lot of information in a short amount of time. And so just before we kind of jump ahead to the case, I just kind of want to ask you kind of what your thoughts on this, since you've just reviewed all this literature. And I think you've highlighted what the field has done a really good job of over the last 10 to 15 years, which is finding reasons to hold off on operating and trying to optimize the patients. And we've done that often of each comorbidity in a vacuum. So there'll be an obesity analysis, there'll be a smoking analysis, there'll be immunosuppression analysis, an A1C analysis. And what was really nice about the first study you showed was that it showed that when you match those together, and there are multiple comorbidities, that might be the key as to why maybe some of the individual analyses don't show a difference, because surgeons make exceptions if someone's smoking but they're thin and less obese. And so it becomes a really complicated algorithm. And like you said, it probably requires an individualized approach to each patient. And so I guess my question is have we created so many different check boxes that we're perhaps delaying or withholding surgery maybe, and the pendulum has swung so much towards optimization that we're putting so many people in the queue, and perhaps we've overdone it a little bit, particularly when you look at some of the differences in terms of smoking and immunosuppression that are often negligible.
Yeah, I think honestly, that's exactly. I think when you want the data to fit weighting, you can find the data to fit, optimizing the patient. But I think looking at the patient individually and being like, all right, where is their actual nadir? Where will they be okay enough? They're not going to be perfect. Where are they going to be okay enough in terms of, if they're obese and they're a smoker, like what's going to be the best scenario for them in terms of optimizing their repair? And so I think looking at this more has taught me that you aren't going to have a perfect patient when you operate, especially with the complexity that we're dealing with nowadays, with patients being, having more operations and coming to you with a second or third operation. So I think it's all about optimizing the individual patient and not optimizing the patient as we see them fit in the perfect cookie cutter.
And when are you more likely, do you think, to bend the rules?
I would say I would be more likely to bend the rules in a patient that's shown me that they've tried to make a difference in terms of controlling their optimization. So kind of like you would look at a patient who's attempted weight loss before bariatric surgery, in some regard of actually trying to make an improvement.
Okay, and what about in regards to the symptoms that they're having in relationship to their hernia?
Well, I guess that's another conversation you have, and that's kind of looking at them individually. If they're so symptomatic that it's preventing them from actually working towards controlling those issues, particularly with weight loss, I think that's probably the hardest thing. Then I think you need to look at when they're going to be most optimized from the individual standpoint. Diabetes seems like it'd be easier to really actually get control just because there's good medicine for it. but the weight loss thing is really a tough conversation to have with them.
Yeah, I think, the hard thing to sort out is the pain versus actually someone being admitted for, bowel obstruction. I think that's often what's hard. How do you sort out when someone's having just partial obstructive symptoms and pain? To me, like if someone's admitted to the hospital and has had an NG tube in the last 6 months, that's, I'm going to be a lot more flexible with that patient than someone who's had pain for 3 years, for instance. Because a lot of times the pain of just having something incarcerated, if they lose weight, will start to improve a little bit. But again, that's a case by case scenario. All right. I guess I'll open it up real quick. I think we're not too far behind in terms of time. So if anyone else has questions, feel free to put them in the chat, and we can maybe get them to them at the end as well. Otherwise, Sergio, why don't you go ahead and fire up your presentation?
All right. Let me share my screen. Can everyone see my slides?
Yep.
All right, so yeah, I'm Sergio. I'm a PGY5 at UTMB down in Texas. I'm going to be doing the educational topic and brief introduction and going over 2 cases. So just to start, I've always heard people comparing surgeons to pilots, and it's always a weird comparison to me, because if you think about it, pilots, they fly on those fancy Airbuses or fancy military aircrafts like you've seen on Top Gun. And if there's any slightly something wrong with the aircraft, the pilot's going to get another one. He's going to refuse to use that aircraft. And if you think about surgeons, that just doesn't work. And if you think what would be a patient that goes to the doctor all the time, is completely optimized, and has a very small problem because he detected early, it will be patients more looking like this. You see this is Shakira on the Super Bowl. If you zoom in enough, you would see her hernia. It's very hard to see. So, I mean, this is just not real life. This is more like real life. This is just human nature and how the healthcare system works. And it's how we're going to see on our hernia clinic. So, and that's what we're going to focus on today, is a comorbid patient. And when we were looking at the ventral hernia working group classifications, the patient with comorbidities, smoking, obesity, diabetic, immunosuppression, as Matt said, just a couple examples of those comorbidities. And this paper already presented just showed that you want to try to avoid getting your patient into the cycle of complications, because once you have a complication, you're going to have a recurrence. And once you have a prior repair, you're going to also have an increased risk of complications. And that's why most guidelines and most experts recommend avoiding surgery on smokers, diabetics with A1C more than 8, not operating on obese patients more than BMI of 50, and between 30 to 50, optimizing them before surgery. And that's the rationale is from those studies, and also usually large database studies. Most of them show those risk factors that we've known is the BMI, is the smoking, is the recurrent hernia. Those are always the same risk factor in those papers. This one, they looked at more than 30,000 patients using the NISQIP database. And if we wait enough for these patients, we're going to look like this in the office. If we wait for the patient to have the A1C completely controlled, the BMI less than 30, is smoking cessation for 4 weeks, we're not going to operate, basically. So that's why people have been pushing the boundaries a little bit. And you see here, this already presented the paper comparing operating on smokers versus non-smokers. So I'm not going to repeat myself here. This one is just a recent one from the QC as well, using the A1C cutoff of 8. Versus less than 8, and we can see also there was no difference in outcome. So again, just challenging a little bit the idea that you need to set up hard cutoffs for every patient, and it needs to be an individualized discussion with the patient, with each patient that you see in clinic. So how can you guide yourself when talking to patients? Because there is so much conflicting data out there. Like, how can you navigate through that? And there are a couple of tools. There are a couple of surgical risk calculators. The NISQIP risk calculator is one of them. It's more generic, not really specific to hernia. But there are 2 ones: the Oracle, which is the QC one, and the Carolinas one from the Carolinas Medical Center group. that are specific to hernia repairs. And it can be very useful, especially when you're talking to the patient and you show on your phone or tell the patient to download the app and actually put their own information in there. It might be actually a useful resource to try to engage the patient to see, hey, maybe if you lose a couple of pounds, you're going to decrease your risk of complications by this much. So might help the patient to motivate them a little bit to opt for preoperative optimization. So it might be useful. So if we can go ahead, we can go to the cases now. This first patient is a 41-year-old male. He was involved in a gas explosion accident. He was working in one of those plants we have here in Texas. He had a 55% TBSA burn, mostly to the back, face, and the legs. In 2019, he had a complicated hospital course, had Ogilvie syndrome, had a cecal perforation, required right ham. He had an open abdomen because he was unstable at that time. Stage primary fascial closure, dehisced a few days later, was managed with wound vac therapy, and also had a PE, DVTs requiring IVC filter, and was on Eliquis as well. And his BMI is 44.9. He's seeing you about a year after this accident. This is him in clinic here, as you can see, and this is the CT scan. Let me go. Just scrolling down, you can see a kind of calcified mass over the midline over there. And I'm gonna get to the ventral hernia from the midline incision. So that's the CT scan. And if I put the patient on the surgical risk calculators, this one, the last one is the CEDAR one from the Carolinas group. He has a 35% risk of complications if we operate on him now. And the QC calculator actually wouldn't allow me to calculate his risk because he was too heavy. So that's open the floor now to see what would you do with this patient. Dr. Rosen, what would you do?
Well, just a couple things. So interestingly enough, just the CEDAR and Oracle are both two good tools, and you should use them depending on what you want to do. If you never want to operate on somebody and scare everybody off, you should use the CEDAR app, because I can't believe it's only a 35% complication rate. And in fairness to the CEDAR app, I'm not being critical of it. The CEDAR app measures any complication, not necessarily major. And Oracle, if you do it, actually the complication rates tend to be much lower than you were hoping for. And sometimes it doesn't make it that easy to kind of, if you tell people, hey, if you lose 30 pounds, what happens? And like, not that much happens. And they're kind of like, I'll take my chances. So you got to be careful with these apps. And I think you kind of have to know the limitations of them. Just personally, if I ever use the Oracle, I tell people kind of that this is your range of complications. And I usually end to like the higher range, but these tools are funny if you use them in practice, because depending what you want to do, it might not do that. So for me, I mean, with this guy, listen, he's been through a lot. If you go back to that CT scan, I'll show you something about that scan.
Yeah.
So obesity, as everybody knows here, it's very different. And where the obesity lives is very different. And people with very large hernias, a lot of times, particularly men, they'll have a lot of intra-abdominal obesity. And for big hernias, if you lose some weight, you can get a little bit more working space. This doesn't look that bad to me. And if you also look, you know, he's not that thick right where you need to cut. So like for me, this would be no minimally invasive options. I'm sure maybe if you had a robotic option, maybe you could talk about that, but that heterotopic ossifications, I can't imagine how you're going to do that on the robot. So, and he's got kind of a nasty scar there. So for me, I would kind of counsel the guy to lose weight. You know, I'd ask him to lose 30 pounds. I probably, as I'm getting older and older, I wouldn't require that as much as I did in the past. but I would give him that you've been through quite a bit. You know, things could get worse with this hernia operation. But if he was symptomatic, personally, I'd probably fix that open dart approach. I used to be much crazier, and I would make this guy lose weight, come back in 3 months, set a goal. I just, most of the time it turns out fine. So I'm not as much of a stickler as I used to be honest, mostly because Clayton's told me that nothing really matters. But kind of just one last comment to that, because you guys didn't really mention this, and to add on to what Matt said, I think, Matt, like all your points were super well taken, but the one thing that I was going to say is, which is missing in a lot of that data, is what type of procedure you're going to do. And if you're going to do a big skin flap, if your procedure choice is an onlay, which is fine, then things like smoking, obesity are going to matter more to you than somebody who is doing something potentially retromuscular without raising skin flaps. So all that is hard to fish out. Even in the QC, sometimes it's like hard to weigh in on all that because there's a lot of surgeon bias. But I think, if you're not raising skin flaps, I'd be okay to do that. So yeah, for me, try for 30 pounds, see him back in 3 months. If not, I'd probably just fix it.
What about you, Dr. Petro? Anything different?
Yeah, I agree. So I would probably, like you said, I'd probably read the room and just get a sense of how symptomatic the patient is, how miserable he is. I think, to be honest, if you had not told me the BMI, to look at that picture, that CT scan, I would have never guessed that his BMI was in the 40s. Just to glance at it, I said this is a BMI of 34, 35. And so I wouldn't have thought anything about walking in the room and signing the patient up for surgery. But if I knew walking in it was in the 40s, then I'd kind of feel out where the patient is. And if, he has, again, I think the thing that I really take into consideration, and Matt mentioned, is how far have they come already? If he says, hey, listen, I knew I was going to have to lose weight before I came here, so I've already lost 20 pounds, much more likely to like reward that patient with, let's get it done while you've already put the work in. Or, if he walks in and says, hey, I lost 20 pounds and I want to keep going, absolutely. Let's take 3 months. Let's see how low you can go. And then, like he said, the hardest part of that case is getting that heterotopic ossification down. That's going to be really brutal. So this is going to need to be open, and he's going to want that cut out too, because I'm sure it bothers him.
Hey, Sergio.
How often have you guys seen this?
Sergio, let me ask you a quick question. Here's a good little tidbit. Let's say you try and get that heterotopic ossification out with the Bovie and it won't come out. What do?
We'll get there, Dr. Rosen.
Come on. All right. Wait, I was going to say.
Do we have that part of the case?
Yeah, I took some meteor pictures of it.
Good.
I'll show.
Go get it.
We'll get it. But I was going to say, how often have you guys seen this? Because to be honest, I've never heard of it. And I was quite surprised in the OR and in the seats when I was looking at the scan when I saw it.
It's actually common in post-trauma people. It's actually not uncommon at all. And a lot of times you can see in CT scans, it can actually track all the way in people's mesentery. It's just a kind of a hyper-inflammatory response where the stem cells start depositing bone. And it can be actually, see right there, that one might even be getting a little bit of
this one was just stuck to the bowel, actually.
Yeah, it can actually be within the mesentery.
Yeah.
You don't always have to take it all the way out, but this is going to be in your way.
Yeah, the first time it happened to me, it was like a wishbone coming off both ways. I was like my first year of practice, I scrubbed out because I thought I was resecting the 12th rib. And I was so confused. I would say I probably get one every like 9 months.
It's common with repeated laparotomies, and also when you go through the xiphoid, you tend to seed the cells into the incision.
Yep.
And it usually is just in the fascia. It's not rare.
Yep. I also find it in, like, if you're in a major trauma hospital where people have a lot of open abdomen stuff, you'll see this, quite frankly, not as pronounced as this. Like, this is pretty pronounced, but you'll often see something along the incisions.
All right.
All right. I was going to say one last thing. The worst part about this case, if you're going to do it open, which, I mean, you have to be fair and discuss this, especially as you become older, is this is just hard on your back and your shoulders. Like as people's BMIs go up, the truth is to get exposure, it's really, really hard. I mean, it's something you have to consider. And some of these people, I'll just tell them like, I cannot lift up what I need to do to see. So not in this guy, but that often, as somebody who's completed 6 months of physical therapy on both shoulders, it's something to think about.
Yeah, so we also agree with what everyone said. We told the patient that kind of what we wanted his BMI to be less than 40, so lose a couple of pounds. And we gave him a follow-up of 3 months. And this is the comparison again, as Dr. Rosen said, the Oracle is very different from the CEDAR, the way they show the complication rates. But so he returns to clinic 3 months later, and his BMI is 44. So he lost 0.9 of his BMI. So I don't know if anyone would go ahead and do it or would wait a few more months.
Just fix it. Come on.
Yeah. So we waited an additional 3 months, and he actually got down to 39, Dr. Rosen. There is hope. There is hope in everyone. But he said he couldn't do it anymore, that he needed to get it fixed, and we ended up taking to the OR. We held the Eliquis 3 days pre-op. I don't know what's the cutoff for other people there, but we held it 3 days. And this is the heterotopic calcification coming from the xiphoid. And like I thought I was gonna bove it through it, but I actually had to use a bone cutter that he used for like toe amputations and all that stuff. And it was tough. It was a lot of force to take that thing out from the xiphoid. And this is the specimen there. And here's the final aspect of the mesh fascial closure. And the case went well, but until he comes back, right? So he was discharged on post-op day 6 because he had some ilia, so it took a little longer than the usual. But let's go now, Matt. So this is your second month of fellowship. You did this case, and this guy came back to the ER, draining some stuff from the wound, and this is the CT scan. What would you do?
You said it's draining out of the wound. Yeah, I mean,
yeah, it's leaking a little bit, the wound, some bloody stuff.
I mean, it honestly, from that cross-sectional, it doesn't look like anything that you'd actually really be able to put a drain in and have any effect on. So I feel like I'd probably start by just like open up the skin and see if you can get a vac there or something. But it looks like something that eventually is going to need some sort of long-term wound care at least.
Anyone else? Dr. Petro?
Yeah, that looks pretty concerning. That's a pretty nice size collection there. So, I mean, again, I might try to open it up to the bedside, but I'd have a pretty low threshold to open that up in the operating room and evacuate it and clean it out.
The first thing I'd do is I'd go out of town. I'd go out of town quickly. No, actually, I'm going to tell you something. I think probably the most important thing to do here is just not panic. If the guy, so was he like systemically ill at all? Was he febrile, white count?
No. He was actually doing pretty well at home. It was just draining a little bit.
I mean, I agree with Clayton to an extent that, like, this CT scan looks concerning. You got a lot of air. He's 2 weeks out. It interestingly looks like wider than what I would have expected, because unless you guys raise skin flaps or something, like you've got a pretty big pocket, bigger than the hernia was. But what you have going for you is it looks like most of the fascia, maybe not all of it, but most of it is together. So like I wouldn't fault somebody for putting a perc drain in there, but if he wasn't systemically ill, I might mess around with some stuff. But if he had a white count, if there was a lot of erythema, like this would be a very low threshold to get back to the operating room and just make sure that like you're not missing a potential necrotizing soft tissue infection or something. Because that scan, no doubt, looks fairly abnormal.
I would bet it's in just a hematoma that's kind of organized. I think if you try to drain it percutaneously, it's probably not going to come out easily. So I would agree with going to the OR.
Yep.
Yep, that's exactly what he had. So we took him to the OR. He had an infected hematoma, and this is kind of the aspect after we clean it up. So what to do now?
I got a question. It's
Yes.
related to this picture. You guys did a TAR, is that right?
Yeah. Oh, yeah. Sorry, I forgot to mention. Yeah, we did our open retromuscular repair bilateral TARs. Yes, sir.
So when you do a TAR, and it looks like you guys probably did a pretty extensive TAR, that's a pretty big piece of mesh in there. What's the blood supply to the posterior sheath?
Epigastric vessels, or
Well, you separated all that though, right?
yeah.
I agree, Don. So, this is actually, I personally think this happens way more commonly than we know because you probably would have never seen this had you not had the hematoma, but you see all that like ischemic posterior sheath behind you there.
Yeah.
That looks like crap. And the reason why that's relevant is because when you do these R-taps and you put uncoated synthetic mesh right under that completely devascularized peritoneum that you take off, that's like a half a cell layer thick. I bet you if you go back and look at a lot of those, all that stuff is dead. Again, it might not always cause clinical problems.
I'm going to play devil's advocate a minute. I think what you're looking at is the area that is not granulated, and it's going to probably take another 4 weeks or so for granulation tissue to come up in there, but it's going to come.
Anyone
But at
else?
like 11 o'clock, that like kind of,
Yeah, it looks
like,
kind of
I don't
ugly,
know
but
if
that
you
could also
describe
just be
that,
some
but,
dead
like,
fat.
yeah, maybe.
Sergio,
But
then
that's right in the midline where you shouldn't be having a bunch of fat on the retromuscular. So like that
True.
should be, I mean, what do we always say? A retromuscular hernia repair is the place, perfect place. It's well vascularized tissue on both sides. Is it? I don't know
I
if it
still-
is.
I still-
I'm asking. I've often wondered when you take all this stuff down and do a TAR and you look at that peritoneum or some of that, and you've divided all those perforators from the ones going posteriorly, like what is giving that a blood supply? Clayton, what do you think?
I don't know, but I think that in these moments, it is so easy to look at this picture and say that the patient was obese, or it's synthetic mesh that's exposed and now you're hosed. When in reality, you just wonder if you had done a perfect dissection and you didn't have a bunch of holes in the posterior sheath and you weren't like doing a bunch of running 3-0s to kind of like, kind of piecemeal everything together, which, listen, I've been guilty of. You do wonder if now you're sitting with good tissue underneath that mesh that does have a blood supply, even though we don't understand what it is. I have to believe that if you do a good dissection and there's not a bunch of holes, that you're going to be more likely to have tissue underneath your mesh that's alive. And if the tissue underneath your mesh is alive, you're going to get out of this. It's going to all granulate through. And unfortunately, I feel like I hate to admit this, but I've been in this situation enough that if the tissue is not alive, everything else will granulate in, and the only way out of it is trimming out the mesh on top of the little pieces that don't granulate in, and that's where you're going to end up getting your recurrence. But this is not the mesh. Phasix isn't going to get you out of this mess. It just might save you the step of having to trim the mesh out because the bacteria will chew it up. This is just necrotic posterior sheath. I don't know why it's necrotic, but I have to believe I want to believe that there's probably a technical component to it.
Maybe it's my fault, Dr. Petro, but
Was that your side? Which side did you do?
I know you didn't want to say this out loud, but that's okay. So we basically managed him with wound vac, serial wound vacs. The wound actually ended up granulating well, and a few months later, we did a skin a partial thickness skin graft, and he actually was pretty happy with the result despite everything what happened. So
Did you get that necrotic piece to granulate through?
yes.
Okay.
Can I just ask a question about wound vacs? Megan was like all jazzed about wound vacs today in clinic. Would you all, like Clayton, would you put a wound vac on this?
Not out of the gate, but eventually, yeah.
Like after,
If it's like two or 3 weeks out, yeah, I probably would.
after you get a granulation tissue base in there?
Yeah.
What's that sort of purulent looking stuff down at the bottom right side?
I think it was just from the vac that was just took out. It was just like exudated. I wasn't there when they took this picture, but I was told it would look okay. And this is the not final result. It has been a few other months, and we haven't heard back from him. He's doing okay, as we hope so. But
Well, you know, I mean, if your posterior sheath is dead and separates, you've got omentum and bowel underneath. It's going to probably give you a little bit of capillary blood flow up there. So I tend to be conservative on this stuff.
Yeah, I'll be honest. I'm shocked that you got that to granulate through. Usually, if what's underneath is dead, that's usually everything else will grow in like it did, and you end up having to trim out a little bit.
I don't think this story's over just yet. I don't think you guys listen, and I don't mean that negatively. Like I think that you're going to get through what is like a horrible, like I think this is kind of the natural progression of what Clayton was just talking about, which is that like this isn't the end of the world. Everything has to come out. You're all screwed. This is the end of like medium weight, maybe even heavyweight polypropylene mesh infections, which is like at that 11 and that 530 position. That story is not over. You'll be out of Texas before those things start spitting, and somebody's going to trim that stuff off. And that's actually the beauty of this, is that you can just trim that stuff off, and then it will probably granulate. And maybe I would just tell this guy once a year, I might see you, and we'll just cut a little bit of mesh out. And listen, that's the best we could do. I mean,
Right, you may get a little recurrent hernia in that area, and then you can go back and fix it another when his BMI is down to 25.
Or lap, or by the way, you could do a lap ventral if you really wanted to. You can maybe sneak in if the adhesions weren't terrible, and do kind of that as the final progression. But again, I don't think this is a loss. It's just, you know, not everybody's getting an A+ outcome.
Yeah.
You have to be patient. Sometimes the hardest thing is to do nothing.
Sergio, I just have one question. So do you think if he dropped even more weight, this wouldn't have happened? Or like, what do you think precipitated this?
I think it probably has more technical component, plus maybe weight, aliquots played a role, maybe. I think it's a combination of things. But of course, there's I think, big component of technical on this case.
Oh, let me just answer my own question. Ask you. A better way to get rid of that heterotopic ossification, in my opinion, is you can use the giggly saw, you know, what they do for like the knees, or the best way in the world to get rid of that stuff is just have them get a sternal saw for you. And you just go up to the top, put a malleable underneath, and you just take the sternal saw and it cuts it like butter. It's incredible.
But
And the nice part about that is you get a flat edge, versus when you come at it with like Rangiers, it's like always kind of like a little pointy to me.
And you reseed it sometimes. But I've also found the cutting current in the bovie turned up high often gets through this stuff too. You just kind of go around the edge. Just go around the edge though. The problem is where it's attaching at the xiphoid.
Sergio, I have two technical questions. How did you close the fascia anteriorly, and did you leave a sub-Q drain?
Yeah, we left subacute drains and we closed the interrupted figure of 8 PDS sutures.
Yeah. And you left the sub-Q drain. Did you leave it in for a while, or did you pull it before you discharge?
No, they were still. No, I think we discharged. We took out the drains before discharge.
Yeah, there's a big sub-Q space. I just leave those in. You know, the retromuscular drains we take out earlier because we don't want to seed the mesh if we leave them in too long. The sub-Q drain, you really lose nothing by leaving that in, especially if it's a big dead space.
I don't know if you guys remember or not, but did you have any inferior epigastric injuries during the dissection or anything like that? Did you have to clip it at all? Or?
Not that I can recall.
Because if you go back to the CT scan, I'll show you something on that. Pull up the original scan that you showed us. I'll show you something about the CT. It's like a marker for like what's going to be a hard case. Look at his right rectus muscle as you come down. He's had an injury to his right rectus muscle already, probably with the neurovascular and a vascular during one of his operations. If you look at there's asymmetry to the right rectus muscle, like it'll start right here. See, right there, the right rectus muscle is totally out compared to the left.
Yeah.
And there's even there's a clip right there that's probably on his epigastric. And if you can kind of identify those things, it can make the dissection quite a bit more difficult in that area, and you can get more extensive vascular injuries in those scenarios as well.
I bet he had a stoma. Did he have a stoma after the perforation for Ogilvy's? And then they reversed it. You have an endoleostomy maybe, and then they reversed it.
No, I don't think he had a stoma.
Oh, okay.
Doesn't look like his scars like he has a stoma.
No, he didn't have one.
Okay.
Yeah. But sometimes those injuries to those muscles, you can pick them up on scans. And I mean, there's nothing you can do about it, but just be aware it's going to be a hard dissection.
Yeah.
Oh, here we go.
So let's go to another case. See how that one goes too. 71-year-old female, liver transplant in 2018, complicated by multiple takes back for bleeding. She's a smoker, is on tacrolimus. She has a bulge there and a hernia that's causing significant pain. Her BMI is 24, and this is the CT scan.
Easy.
All right. So we told her this is the risk if she keeps smoking versus she quits smoking. We can see on the oracle actually there is no difference basically. But what would you guys do?
Mike, you want to go first or me to go first?
Well, let me just again, like this hernia, I think just aside from preoperative optimization, like I just take a moment. I always like to say every hernia operation has three things, every single one of them: a patient, a surgeon, and almost always some prosthetic. Those are the three things you need to think about. This hernia is not for the casual hernia surgeon. So like, before I tell you what I would do, this one is going to be difficult. And there's, if it's a transplant, she probably has a large right subcostal. It looks like she probably has an extension over the left. She has a vertical one. So this is a very difficult hernia operation. And so if you gave me 24-year-old perfect health, I'd be like, this is not for the weekend warriors here. So for those people who do a lot of this stuff, then I would just say 5 years ago, there is no way in a million years I would operate on this patient if they were smoking. And today I would tell you that if anybody made her quit smoking, you're a good doctor and good for you. Use her chevron incision. I wouldn't elevate skin flaps, and I put a big old piece of mesh, but that's just me.
Anyone else?
Ben, what would you do? She's in your clinic tomorrow.
Yeah, no, I saw one of your patients like this, skin only closure, 5 take backs. She's on my schedule now. So I would go through her chevron incision, and I wouldn't make her stop smoking either. So, but yeah, this is a tough case. Make sure that Rosen's around.
Anyone would do this laparoscopic or robotic?
So here's the reason that I think that a lot of us, at least our philosophy, we tend not to go after when you scroll through the scan, what you're referring to is the defect with the incarcerated bowel on the lateral extent. And the hard part is like all the rest of that. It's only going to get bigger with time. How far out is she from the transplant?
About 2 years.
Yeah, I mean, our philosophy is to try to fix the whole thing, including everything else in the middle that's clearly bulging, because I just think that that's going to get bigger with time. And so we are like super aggressive, but that is a really good point of like, if you scroll down and just look at that one component with the incarcerated bowel, could you maybe get her out of any acute trouble by just going after that? But even that, like, even a minimally invasive approach for that, like getting all those adhesions down, getting the bowel out of there. And then, how good is the tissue that if you were going to do it, like say robotically, how good is that tissue that you're closing? You're kind of just.
So it would be an open retromuscular repair with bilateral TAR likely on this case.
That's kind of how we approach all of these, because we just see so many of these because they do so many liver transplants at the clinic. We end up just going full go, and we end up fixing the whole thing. But I don't know. I mean, would anybody else try this in a minimally invasive fashion just to get everything down and just close the small hole with the incarcerated bowel? Looks like Don, you're nodding. That's how you would go after it.
Our transplant program for a long time did a delayed primary closure of the fascia after liver transplants, and they had over 50% hernia rate after those procedures. I just did lap IPOMs on all of them. You're not going to close anything here, unfortunately. You're not going to get primary approximation of any tissue. You're going to be bridging no matter what you do with something, and you might end up putting absorbable mesh to bridge, and then a permanent mesh across whatever you think you've brought together. But once they've created that Mercedes incision, there's no good tissue, and it goes right to the ribs. And basically we end up securing the mesh to the ribs. But surprisingly, the adhesions usually are not very bad, except right around the liver. And the adhesions usually right around the liver are usually the worst, where it's stuck to the costal margin. And never operate on somebody on sirolimus.
Yeah, that's going to be just because you're running out of time. So that's what I was going to say. This patient was not on sirolimus, but apparently from what I heard, and I saw some literature that increased the wound complication rates, but I heard it's pretty bad.
6 weeks. If they know that with enough time, the transplant folks will always, they can take them off of it. And then, 6 weeks after they're all healed up, then they can put them back on it. But they have ways around that.
I would just add one thing to what Don said. I just to be fair, I think that often there's a little bit of bias to like overdo it. And that's a fair point, especially if she was pointing to that one spot where that bowel was. I think that's something to think about always. It's just fix the acute problem, accept it. The only reason I've hesitated to do that, but again, I agree with the concept of it, is that then if they come back later with a bigger thing in the middle or to the side, then it really does make doing TARs and stuff like that much more difficult. But they don't often. I think fixing the problem they came to see you with in these people is not a bad idea.
So we told her to come back to clinic after a month, and she stopped smoking. We continued the tacrolimus, and we did a robotic retromuscular ventral hernia repair with bilateral TAR. So these are a couple of pictures. This is the lateral defect there. We took all the adhesions down. There was the colon was pretty stuck to it. This is we performing the TAR. This is the defect, and the defect after closure. This was after the TAR on that side. The patient also had a midline. So this is the posterior layer closure, and this is kind of a little bit of the final aspect of the retromuscular space after both sides were developed. We can see the contralateral trocars on the top of the bottom image there. This was the midline. She had a tiny hernia there, and she had some diastasis, so we completely plicated that as well. and with absorbable V-lock. And this is an area of weakness on the across the chevron incision, so that we also placated, was right on the subcostal area. And after we placated it and closed all these areas, we put a large microporous polypropylene mesh. And the patient was discharged post-op day 1. This is the picture post-op day 1, and the CT scan at 1 year is there was no signs of recurrence. And she's pretty happy.
That's awesome. How long did that take?
It was about 5 to 6 hours.
That's good.
Did you keep her supine, or did you bump the right side a little bit to be able to get back farther? Because that's often the limitation of, when you're doing these robotic retromusculars, getting lateral enough. And often, it's really nice for midline stuff, but for something as lateral as that, I imagine you had to at least put a bump or something up on that side, no?
I wasn't in that case in particular, but I've seen a similar case, and we did it supine. We rotate the table sometimes, but I think it was supine.
From looking at those ports, it looks like they probably, it looks like they just went supine.
So,
Yeah,
I know we're running up on time, but just out of curiosity, if you knew you were going to do this robotically, why did you make her quit smoking?
That's a good point. And to be honest, I don't know. I think it's worth trying the patients, try to get themselves motivated to undergo the surgery and to make sure he's going to be compliant as well post-op. But I think it doesn't hurt to wait for a month and see if the patient is willing to participate more in their care. I think it was worth it in this case.
Yeah, you never know if you're going to have to. I mean, I would have gone into this thinking there was a high chance of conversion.
I would think that the smoking is going to add to the problems with wound healing, not just infection rate, but with the strength of the repair. You're already battling the immunosuppressive drugs. I think anything you can do to make it heal better would be worthwhile.
Sergio, where's that CT scan? The 1 year one.
Let me see. I can
Exactly.
You had every other picture, every other image, and the CT scan. Just we're supposed to take your word for it. Like what?
I think we're out of time. No, I'm just kidding.
Sergio, think it through, bro. Think it through. Stick to your story. You might not want us looking at that CT.
Okay. So I'm going to stop sharing then.
Okay, good night, everybody.
Are we good? Are we done?
Yeah, I think
Yeah, all good. Yeah, all good. Next month, we're going to talk about pre-operative optimization. What are the options? So great discussion, everybody. We'll see you next month.
One quick announcement, everybody, before you guys jump off. Thanks so much for putting this on. This Thursday, for anybody who's going to AHS, I think it's 8 a.m. We have a QC session at AHS. It'll be 4 of our embedded randomized control trials, some really good kind of provocative data coming out of some of these trials. 2 randomized control trials, and 1 involving robotic ETEP and 1 involving robotic TAR, with some pretty interesting and compelling data. So please make it there if you can. And as Clayton said at the beginning, just to kind of rehash, if you're interested in our surgical coaching opportunity with Caprice Greenberg, you can reach out to Aileen, myself, or Ben, and we can put you in touch with them to be that. It's a really phenomenal opportunity, and it's just going. And Sergio, just like at M&M, when we come back next month, we'll let you show that CT scan, so I'll take a look. All right. Thanks, everybody. Hope to see you guys at AHS.
Right.